Thank you for joining us on this show today. We have a special guest. His name is Russell Roberts. He's a radiation oncology physician in training in his fourth year at the University of Mississippi Medical Center. He's trained at the Mississippi State University. He's trained at the University of Mississippi Medical Center, and he's a believer in Christ. He's a father, he's a husband, and he's a faith believer. He's a member of the National Residents and Fellows Council of the Christian Medical and Dental Association, and he's going to be sharing his love for family, for faith, and the future of radiation oncology with you and I. He's going to tell you about what he sees as the future of medicine in our current diverse spheres. You don't want to miss this show. He has a philosophy about how you can merge your life as a Christian and as a professional into one. He's a young man. He's a member of Park Place Church. He's the head of the deacon board. He's going to be sharing his life with you. You don't want to miss it. God bless you in Jesus' name. Hi, this is Dr. Toby, your host on Health and Wellness. Thank you for joining us. What a pleasure, what a delight to have you on the show with us today. I have a guest on the show. You'll be delighted to have him. His name is Dr. Russell Roberts. Dr. Russell Roberts is a trainee in radiation oncology at the University of Mississippi Medical Center. But most importantly, he's a believer in Jesus Christ. And he's going to be sharing his heart about his faith, his family, and what he sees as the future of medicine in radiation oncology and some other aspects that concern radiation oncology. He trained at the Mississippi State University, went on to the University of Mississippi for his medical school, and is currently in almost fourth or third year with his radiation oncology training. What a delight to have a man of such high intellectual esteem and Christian testimony with us today. I want to welcome Dr. Russell Roberts. Thank you so much.
Thank you, Dr.
Real pleasure. Thank you for coming on the show with us. So the show is Health and Wellness, and we started this about 6 years ago to help the Christian community especially get educated on the simple things about healthcare. Jesus said in 1 John 3:2, I wish above all things that you prosper and be in health, even as your soul prospers. Unfortunately, that's not the reality in the church. We have a lot of sick people. We have a lot of soul wounds. And I felt that if I can bring my medical knowledge and I believe God's inspiration, we can educate a generation of Christians in this part of the country and maybe all around the world to take better care of themselves. So that was the motive behind the show. And God has given us such phenomenal support that He has kept it running now for 6 years going and almost 7 years. And you're just a delight to have you on the show. I have never had a radiation oncologist on the show, so I want to say that you are the first in that pathway, okay? So let me start with asking you, who is a radiation oncologist so that we understand, because my viewers, many of them are 6th grade, maybe of them are 12th grade, many of them are, didn't finish college. So radiation oncologist sounds like oncology and then radiation. Can you put the words together and give us a nutshell?
Yeah, of course.
Right.
So radiation oncology is a small field with a very specific focus. We are the doctors who treat cancer with radiation. That's our main job. We start from the beginning. We treat young to old, head to toe, but our job is to do the radiation part of cancer care.
Okay. And I know it's a very rare field, and there are not too many programs in the country. Mm-hmm. And obviously there's cancer is widespread. When does a radiation oncologist get involved in a cancer case? Is it towards the end, the middle, the beginning? How do you know when to contact a radiation? Who contacts the radiation? Is it the patient that contacts the radiation oncologist, or is it the other oncologist? How do you get in touch with a radiation oncologist?
So typically we are brought on board after someone has been diagnosed with cancer. We are known as tertiary care. So primary is kind of the person you go to whenever you have a problem come up.
Like me, I'm a family physician. Right, okay.
So let's say they said, Dr. Moma, I have a new lump in my breast. You would do some initial testing, but once you saw something on, say, a mammogram that was concerning, and they had diagnosed cancer, you would send it to a chemotherapy doctor or a medical oncologist. who often functions as sort of the grand coordinator of everything else.
Okay.
And it's the medical oncologist oftentimes that brings us on board. So if it was breast cancer, we would discuss their case at a tumor board where we have
Okay.
lots of doctors come around and discuss the ideal treatment plan for a case, and then we would come on board and meet that patient.
So not every cancer requires radiation.
Not every cancer.
Okay.
So 2 years ago, about 1.8 million people were diagnosed with cancer, and throughout the course of those treatments, or of all those 1.8 million people, about half will require radiation at some point.
Okay. Because from my knowledge, I think a lot of the head and neck,
Mhm.
and maybe ENTs respond very well to radiation,
Mhm.
and maybe we call them the anal, carcinomas.
Mhm.
I think those respond well to radiation too.
Mhm.
So, so half of them respond to radiation. Okay, that's interesting. Give us a little bit of the history of radiation. I mean, everybody knows chemotherapy has been there for probably 60 years,
Okay.
70 years.
Mhm.
When did radiation oncology really kick off? Was it in the 70s or 60s or?
So this is off the cuff, but about 120-ish years ago,
Okay.
whenever just the phenomenon of radiation first started to come around and being applied pretty rapidly in a medical setting. Since then, technology has really taken off. Big developments would be figuring out how to shape your beams, how to shape your radiation, finding out different sorts of ways to give it. So you can do it. Sort of the two big buckets of radiation would be outside in, so we call that external beam radiation, sort of like
Okay.
a flashlight shining. We can sculpt those beams through different shaped windows. The other way is known as like brachytherapy. So we're taking something that is radioactive and then placing it near or within a tumor
Mm.
to help treat it that way.
Okay. They did that in prostate cancer
Mhm.
and others.
Mhm.
Interesting. Okay. So a lot of people have heard costs of radiation oncology are very high. And I know it's not very widespread. I mean, for example, in my home country, Nigeria, we probably have only one or two centers
Oh,
of
wow.
radiation oncology.
Okay.
And I can tell you in Africa, it's probably few, maybe 6 at the most, 7. So what's the real reason why it's so difficult to access radiation oncology? Even in America, I think, for example, we have a center in Jackson, Mississippi. We have one in Hattiesburg.
Mhm.
We have one in Biloxi, maybe.
Mhm.
Anyone else?
Yeah, so there are a little under 24 radiation centers in Mississippi.
Okay.
But to get to sort of your earlier question, why is it so difficult to access? Radiation is very labor intensive.
Okay.
It requires a very expensive facility. You have to have a vault or a room that's properly shielded to make sure no radiation gets outside. You have to have a multi-million-dollar linear accelerator to create that radiation. You have to have support staff, people like the radiation technicians who will properly position and deliver that radiation. You have to have physicists who are behind the scenes making sure that we're actually doing what we think we're doing.
Right.
And you have to have dosimetrists there to generate those plans. And all of those people have to be trained and compensated.
Of course, right. Wow. I didn't know we had up to 36 centers in Mississippi.
A little 24, so
Okay,
around
24,
20-ish,
okay.
somewhere in there.
Yeah, there's one here in, apparently this part of Louisiana has the highest childhood cancer rate in the country.
Really?
Because I lived here before. So we've always wondered, what is it about Northeast Louisiana that causes... So a couple of years ago, a group of physicians and the community hospitals set up what they call the Northeast Louisiana Cancer Institute.
Okay.
And it's an independent body here, and it's run by a friend of mine called James Adams. And the goal is to give access to people in the Northeast area, because a lot of them had to go to Shreveport or MD Anderson.
Okay.
So they now have a center, and the beauty of the center really is that it's kind of inter-hospital based. So they have a center in in 2 of the hospitals, and the doctors crisscross, I guess, due to availability. So that was quite an interesting, because what I've heard is that it's high remuneration to retain a radiation oncologist. Is that true? Is
What
it
do you
the
mean by that?
the payment, the fees, to maintain a radiation oncologist runs in hundreds of thousands. It's one of the most highly paid fields in the
So,
medical world.
so there's a lot of overhead costs that have
Okay.
to be maintained. So
Oh, really?
like that full team of people required to
Right.
treat, all of that has to be paid for.
Okay.
And so that's if we don't have one of those members of the
You
team,
can't do the
then we
same.
can't function.
Wow.
Uh,
Interesting. Wow. So, tell me a little bit about the oncology and the radiation oncology relationship. What is the relationship between the oncologist and, because that's where a lot of people get confused.
okay.
I saw an oncologist, so why am I saying a radiation oncologist?
hmm
Or they'll say I saw a surgical oncologist.
hmm
What do I need a radiation oncologist for? It sounds like a duplication,
hmm
of sorts.
So just like in your sports teams, cancer requires a lot of different physicians and a lot of different people helping out in different ways. So for instance, let's say in our breast cancer, because we have had, unfortunately, thousands and thousands of women who have had breast cancer in the past, we've been able to really hone our care. And we figured out that no, we can't cure these people with just one modality or one way most of the time. So through these clinical trials and through developing different game plans for each unique tumor, we all come at it differently. So a surgeon is very good at local treatment. So they cure where their knife cuts. Radiation is a little bit wider in scope. We're more regional. So we can treat where the cancer was and then where it would likely go. Just in this region, though. Chemotherapy, however, is systemic. So it goes not just local like the surgeon, not just regional like the radiation, but it goes head to toe with a few exceptions.
Okay.
And so by figuring out exactly what kind of tumor a particular person has, we can go back to our playbook and pull out the play, or we can pull out the best plan for each person.
Each person. Wow. What does it take to be a radiation oncologist in America today? I mean, how many years of training to get to your point, to get to your status? How many rivers do I have to cross literally to get to be a radiation oncologist? Because some of my viewers are like, wow, that's something I might like to do, to help people take care of them from as young as whatever age, right? Till, so maybe, so what does it take to become a radiation oncologist academically?
So the road to become a radiation oncologist is a long one, like most with physicians. You have to complete your high school degree, you have to complete a bachelor's degree, then you have to go at 4 years for medical school, and then after those 4, you have 5 more years of residency.
Okay.
So you'll do a year training in just general medicine, we call that the intern year,
Okay.
and then 4 years after that of dedicated radiation-specific training.
Wow. And the lifestyle is, I mean, so a lot of people are interested in work-life balance. How many hours can I spend with my family? Am I on call all day long? So what is the work-life balance of a radiation oncologist? For example, when you graduate from residency, because as a resident, I know you're very busy. But what is the work-life balance? Do you have time to spend weekends with your family? Is it compensated sufficiently to take care of all the needs you may have as a physician, take care of your student loans and all those things? Those are the questions some of my viewers are asking. So
Okay.
you want to just answer some of them and let them know?
Of course. So
Yeah.
the lifestyle was one of the things that drew me to radiation oncology. We get to deal with big problems, but not necessarily fast problems. So we can, it's practice specific, so you can work as hard as you want to. You can work 12 hours a day, 6 days a week. However, that's not in my experience and in what I know of what typical life would look like. They can expect regular hours. Like I said, it can fluctuate. You could do 8 to 5, Monday through Friday. While we are at UMC, as a resident, we take call 1 week at a time from home. And so there are very few radiation emergencies that must be acted upon.
What are the examples of radiation oncology emergencies?
So, for instance, if someone had a tumor growing into their spinal cord, maybe their lower legs weren't working or their legs weren't working as well, and they've progressed over the last week or so. Or if it's blocking a vessel that's trying to get blood into the heart. It's called SVC, or superior vena cava syndrome.
Syndrome. Those are emergencies that require
Mhm.
you to come out and take care of that.
Mhm.
Wow. So there's been a lot of technological advancement, right?
Mhm.
So give us a little bit of your experience. Are we still with the linear accelerator? Is it a smaller machine than it used to be? Do we need as much? I hear there's something called, am I wrong? Maybe uranium, or I don't know, some of those chemicals,
Okay.
those metals they get. Do we still need all those? Are they metals or something? But anyway, what do we, in the world of radiation oncology, what are the instruments that we mostly use?
Mhm. So the bread and butter, the workhorse of radiation oncology is the linear accelerator.
Okay.
The way it works is you generate electrons and then you send them down this tube, and then it strikes a tungsten target. Just
Oh,
like your old incandescent bulbs, you have a tungsten filament.
right.
We use a tungsten target to strike it with those electrons and then to create a photon beam of radiation. It is not radioactive once we turn the switch off, so it's not like we're accumulating uranium or things like that. Um,
So
but
what does the
that's,
physicist come in? Because I thought the physicist was there because there was some, what's the word now? Bio, those things that physicists use, like uranium and all that. I thought there was something that they deployed in their
Mhm.
therapy.
So one, I'll say in brachytherapy, whenever
Okay.
we're taking something that is radioactive um, and placing it in or near a tumor, that is one of the functions of a physicist, to make sure that's properly administered, to make sure that we are following all of our safety protocols. But the role of a physicist is much, much broader.
Mm,
I would say that the bulk of their work is done on the linear accelerator.
wow.
Lots of moving parts, making sure that everything works in concert together just perfectly,
Okay.
because radiation is not something that I can see.
Mm.
It's something that you could very easily make a mistake and not catch it for a very long time.
So the physicist's job is to make sure you're not giving too much. Is that kind of it?
So they
And
make sure we're giving it how much we want to give
right,
and where we want to give it.
where we want to give it.
Mhm.
Okay. Tell me a little bit about the training for the physicist. Is it in the medical center, or do they have their own separate training
Mhm.
program? And what is that? Because some of my viewers are asking, okay, maybe I would like to be a physicist.
Mhm. Mhm.
What is their channel? And did you do physics in Mississippi State, or what was your background?
So at Mississippi State, I did a bachelor's in biomedical engineering.
Okay.
Physicists, their training sort of diverges from medical doctor training. It's my understanding that they would complete a bachelor's degree. Often they would do a master's degree, and then they will complete a physics residency.
Okay.
So, for instance, at UMC, where I'm training as a medical resident, there's also a physics residency there too.
Wow, okay.
That's a 2-year program for people who are interested.
After their master's in physics.
I think.
Oh,
I think
something
the
like that,
master's
right?
it's either currently required and used to not be, or some combination of that.
Okay. Wow. Interesting. So give us your background. You came from Mississippi State, Starksville. You did biomedical engineering, which is a glamorous field on its own. I mean, with nanotechnology and all the
Mhm.
artificial intelligence. Am I correct? It
Yeah.
seems to be on the cutting edge of technology, today. So what you wanted to do something more than just manufacture medical products. Is that, I think that's what a biomedical engineer
Mhm.
does. I could be wrong.
So biomedical engineering, I originally went into it because I was blessed to receive an engineering scholarship at Mississippi State. I was interested in the idea of nanotechnology, this idea that we could make tiny machines that could do amazing things. As I progressed through my training, I became more convicted or more interested in things like cancer research, and that sort of thing. And so that's sort of glossing over a long, long, complicated story. That's how I ended up in medicine.
Okay, okay. But just give us a story, because a lot of my viewers are high school students and they're thinking of what to do now.
Okay.
So your story could inspire the next Russell Roberts, who's pushing his path in medicine. Who knows?
Okay.
Yeah.
So a little bit, getting a little deeper into the story. Something you have to know about me is that as I was growing up, I was very confident in my abilities. I was very prideful, and so whenever I went into engineering, um, that was supposed to be one of the most difficult one of the most difficult majors. As I was progressing through my studies, I wanted to do a PhD in research of some sort, whether it be nanotechnology or cancer. I applied. I originally wanted to go after this thing called an MD PhD program where you could get 2 doctorate degrees, not just one. And really the initial motive behind that was to just prove that I was smarter. And very shortly after that, I got very convicted, rightly, that that was not what I needed to do. I considered some other things, and then ultimately I did apply to those, but in what I think was God's will. I applied for several very prestigious places, did not get those, but I did get in at UMC as a medical student. So the path that God had laid for me was a lot different than I had first in mind. Oftentimes our journeys are not straight lines from A to B.
Wow, that's powerful. And looking at your pathway of research inclination, give me your idea. Do you see yourself in the future doing academic radiation oncology, or are you going to go into the private sector? Because you sound like you're interested in research. I don't know if you're still in that mindset.
Well, we will see what doors open up. But there's some opportunities on both sides of the aisle.
Okay.
I would be very surprised if we didn't stay nearby where we are.
Right.
But there are some very neat opportunities coming up.
And just give me an idea, because my viewers are interested, what is the difference between an academic radiation oncologist and a private? Just give us a ballpark. Does the private guy make 100,000 more? I'm just asking because, there's a reason why people do what they do. Unfortunately, if you're not a Christian, if you're a Christian, it's pretty straightforward. This is the Lord's will. But if you're not a Christian, there are other motives, finances and lifestyle and all that. So what is the difference between an academic radiation oncologist like Dr. Vijay, who's the chair of your department, and those in the private world, the private sector?
I'll be painting with a very broad brush. So on private practice side, you can expect to make more money, a fair amount more money. You can expect, because you're collecting both your professional and technical costs at most places or at some places, you will be more focused on clinic. So you will have a lot of time seeing patients through consultation, so meeting them originally, treatment planning, seeing patients who are on beam, and then seeing patients in follow-up. In academic, you can expect to see patients, but you could also have a certain portion dedicated to other things, whether that be a day set aside every week for research or administration or whatever. Teaching.
Lecture. What do you think the COVID-19 epidemic or pandemic or whatever you call it has it changed anything in radiation oncology? Because you guys deal with human beings. You guys are not virtual. You can't linear accelerate someone through the Zoom camera.
Yeah.
So did you see anything change in the last 2 years in the world of radiation oncology due to the COVID pandemic?
I'll say that the challenge that we face is that for patients getting radiation therapy, they have to come several times to our clinic. Every time they see us and every time we see them, that would be another potential exposure. And so the drive for us is, instead of giving you tiny bits of radiation each day, could we give you a little bit bigger bit, but make you come fewer amount of times? That's called hypofractionating. That was just for an overall safety concern of, can we reduce the number of times that we are exposing you who, let's say, for instance, you had cancer and your immune system wasn't quite as good as everyone else's, and you stood a little bit higher risk or higher chance.
So you see them once a week instead of 3 times a week?
So what that would look like would be, instead of you coming in, say, 40 times for your treatments, Monday through Friday, 5 days a week, it would be something like, well, could we bring you in 20 to 30 times, but we're giving you a little bit more dose.
How do you guys know how many times to bring a patient in? Is it dependent on the size of the cancer, or that's a technical question? Right?
So It depends on what kind of cancer it is.
Okay.
It depends on how advanced it is. It depends on what other therapies are available. There are lots and lots of factors that drive that decision.
And I've heard that you don't take a holiday in the middle of radiation, that you should do it like continuous.
Hmm.
You shouldn't start, stop, then continue. Am I
Hmm.
correct?
In general, that's the prevailing wisdom.
Okay.
We want to make sure, say we have a tumor, just a collection of cells here. Whenever we're delivering our dose, we don't really want to give them much time to catch their breath and start dividing again and to make more. So if we can deliver all of our treatment in one go, we stand a better chance of controlling that tumor and killing all the cells than if we gave it some and then took a few weeks off, gave it time to ramp itself back up, and then finished.
So the average individual gets it Monday through Friday
Mhm.
for a select number of weeks.
Yes.
Okay,
Mhm.
interesting. Yeah, because I know chemo is a little different. Chemo, they tend to do it every other day, or
It it's
depends on the
depends on the
yeah,
drug. They could come in every 2 weeks,
every
every
two
3 weeks.
weeks. Yeah,
It's
different strokes.
continuous infusion. So
So lastly, what are the things you as a radiation oncologist look out for before you administer radiation oncology? Are there some no-nos? Are there some things that are game changers that you would say this is not a good candidate for a radiation oncology treatment?
so in general, radiation is pretty. We can give it to a broad range of people, but special populations that we try not to would be very very young children, because the secondary effects of radiation could develop a cancer from our therapy. So we try to hold off from giving radiation from very young children. Also, people with certain connective tissue diseases,
Okay.
or people who they were born with an inability to repair their DNA as well as other people. They can be a lot more sensitive to
So like the
radiation.
prion disease, something like that?
Prion would be not
Not
necessarily,
necessarily.
no,
Okay.
not like that.
Okay.
Mhm.
So maybe the scleroderma
Yeah, that along those lines,
Okay.
that sort of problem can make
problem.
people more sensitive to
To
radiation.
radiation. Wow. What a pleasure. We've just opened the first leaf of this dynamic world of radiation oncology with Dr. Russell Roberts, extremely intelligent, but also a man of faith. He's going to share with you in the next section his coming to Jesus and how that has revolutionized his practice as a Christian. You don't want to miss it. This is Faith and Power Ministries, Dr. Toby Moma, inviting you to our Holy Ghost night next month. We'll be here December 31st. We'll be bringing in the new year. You don't want to miss it. Oyo Hotel 165. Next month, November 19th, we'll be at Oyo Hotel, 11 p.m. to 4 a.m. You don't want to miss it. Look forward to seeing you. God bless you. Jesus is Lord. Amen.